The following podcast is part of a certified educational activity titled AD Safe, an initiative to build understanding of ARIA and skills needed to guide treatment decisions and support rapid recognition and response in radiology. Access the entire activity and complete the post-test at peerview.com/JCA860. Downloadable slides and practice aids are also available.
Hi, everyone, and welcome to today's programming. My name is Anna Franceschi, and I'm an associate professor of radiology at Northwell Health in New York City, where I serve as director of molecular neuroimaging and director of dementia imaging.
And my name is Patrice Cogswell. I am a neuroradiologist at Mayo Clinic in Rochester, Minnesota.
So it's been a very exciting time in the dementia imaging field since in July 2023, we had the FDA approval of the first new therapeutic for Alzheimer's disease in 20 years since Memantine in 2003. And currently, we actually have two anti-amyloid monoclonal antibodies on the US market for the treatment of early stage AD, which is a very exciting time for the field. However, these new medications do come with a black box warning since there is a relatively high risk of a side effect that we call ARIA or amyloid-related imaging abnormality, which essentially indicates either brain edema, so brain swelling, which we label ARIA-E, or hemorrhages, meaning hemosiderin deposition in the brain, which we label ARIA-H. And therefore, MRI scans are indispensable for screening for these findings, and patients get them on a regular basis, especially early on in the treatment course. So, when we think about our goals for today, we will try and improve your understanding of the pathophysiological mechanisms driving development of ARIA in patients receiving these therapies targeting beta amyloid. We'll also increase your ability to facilitate the detection and diagnosis of ARIA, particularly taking into consideration both clinical context and neuroimaging findings. And finally, also equip you with the skills needed to apply established protocols for the monitoring and management of ARIA in patients receiving anti amyloid therapies, and also providing you with successful strategies for communicating imaging findings across the multidisciplinary AD care teams in order to enable prompt detection, accurate diagnosis, and management of ARIA in the clinical setting. So we'll start with our first module, which will help guide us in the diagnosis and radiological classification of ARIA. So let's first take a step back and discuss the underlying pathophysiology of Alzheimer's disease. We initially have amyloid and specifically amyloid beta 42, which accumulates early and goes on to trigger neuronal death, oxidative stress, and vascular changes, and it spreads diffusely in the neocortex. And then we have tau, which is thought to follow beta amyloid to a degree. And tau is particularly interesting to us since it shows a far better correlation with clinical phenotype and spreads in a predictive hierarchical stepwise pattern, which allows us to assess biological disease severity. And then more recently, we have additional mechanisms and contributing factors that we assess, which include inflammation and neuroinflammation in particular, metabolic changes, and specifically alterations in the IGF-1 insulin pathways, and then vascular cofactors, with vascular dementia being a frequent comorbidity in patients with mixed dementia. Now, on the right side, we have a curve highlighting the CSF and PET biomarkers and clinical disease stage in patients with Alzheimer's disease. And the point to highlight here is that these biomarkers tend to become abnormal prior to the onset of clinical symptoms. And specifically for amyloid PET, it can be abnormal 20 or even 30 years before the onset of clinical symptoms. I already mentioned that tau has a closer correlation with clinical phenotype. So for tau, it's more in the range of a couple of years before clinical symptom onset. And then volumetric MRI and FDG PET, so metabolic PET, which are our biomarkers of underlying neurodegeneration, tend to become abnormal about a year or 2 years prior to clinical symptom onset. Now, the term ARIA or amyloid related imaging abnormality was introduced about 15 years ago to describe findings and specifically vasogenic edema and microhemorrhages that were demonstrated in early clinical trials of immunotherapies targeting beta amyloid. Of course, the recognition of ARIA has important implications for both selecting patients for therapy and also monitoring treatment safety, since the detection of ARIA oftentimes leads to either pause or discontinuation of therapy. And more recently, with new drugs on the clinical market, we are starting to see ARIA in daily routine clinical practice as well. So, when we think about the pathophysiology of ARIA, firstly, it's important to mention that ARIA is an inherently imaging based phenomenon and is diagnosed on the basis of MRI findings. So that's there's a key role for the radiologists and neuroradiologists in detecting ARIA. Essentially, what happens is that we have the binding of the monoclonal antibodies to the beta amyloid, both in the brain parenchyma, but also in the vasculature. And this binding leads to amyloid clearance and loss results in loss of vessel wall integrity. And we can have either leakiness of proteinaceous fluid, which results in ARIA-E. And we have a nice example here in the top right corner. And it's quite analogous to amyloid beta related angiitis, or the leakiness of heme products, which leads to ARIA-H. And we see an example in the bottom right corner. So, vascular heme deposition, which is quite analogous to cerebral amyloid angiopathy. Now, let's take a moment and watch a 3D animation which illustrates how amyloid targeting therapy can result in ARIA in patients with Alzheimer's disease.
Alzheimer's disease and cerebral amyloid angiopathy are both caused by the accumulation of amyloid beta aggregates, which are deposited into the brain parenchyma in AD and into cerebral blood vessel walls in cerebral amyloid angiopathy. When amyloid targeting therapy is initiated, antibody-mediated breakdown of amyloid plaque and mobilization of parenchymal and vascular amyloid beta leads to loss of vessel wall integrity and blood-brain barrier breakdown. As a result, proteinaceous fluid and/or red blood cells can leak into the parenchyma or the leptomeningeal space, which may result in edema, also known as ARIA-E, or microhemorrhages and superficial siderosis, also known as ARIA-H. ARIA typically occurs within the first 6 months of treatment and is detected through MRI imaging. Some evidence suggests that cerebral blood vessel wall integrity improves with continued use of amyloid targeting therapies. Therefore, the risk of ARIA usually decreases over the course of treatment.
Right now, I will discuss the risk factors for ARIA, the presentation, and differential diagnosis. So, first, risk factors for ARIA. These include patient factors such as being a carrier of the ApoE4 allele. An ApoE4 carrier have higher parenchymal and vascular amyloid loads, which have been thought to be related to the increased risk for ARIA. This strong association of ApoE4 carriership with ARIA has led to implementation of genetic testing as part of the evaluation of a patient's eligibility for amyloid targeting therapies and the risk benefit assessment. There's also treatment related factors that increase ARIA risk. So, ARIA is associated with higher drug doses and is more common earlier in the course of therapy. This has led to dose titration approaches, so gradually increasing the dose of amyloid targeting therapies over the early treatment sessions. This has led to a decreased incidence of ARIA in some of the recent clinical trials. Additional factors that increase the risk of ARIA are assessed on a pretreatment brain MRI, and these include the presence of microhemorrhages and superficial siderosis. And given the association of these imaging findings with ARIA in recent trials and clinical practice, it is recommended that patients with 5 or more microhemorrhages or superficial siderosis on their pretreatment MRI are excluded from therapy, again, based upon their increased risk for ARIA. Another notable risk factor for ARIA is the use of antithrombotic medications, and additional risk factors are being evaluated in ongoing clinical trials and clinical practice. Next, we'll discuss the imaging findings of ARIA. So first, ARIA-E, which is parenchymal edema or a sulcal effusion that is detected on the T2 flare sequence. So the parenchymal edema appears similar to vasogenic edema, so T2 hyperintense signal in the white matter. There may also be signal abnormality and swelling of the cortex. This edema must be differentiated from other etiologies, such as the cytotoxic edema of ischemia, and these can be differentiated by the absence of diffusion restriction with ARIA-E. ARIA-E, sulcal effusion, is a T2 hyperintense signal within the sulci, and ARIA has a predilection for the occipital lobes, also commonly involves the parietal, temporal, and frontal lobes, and less commonly is infratentorial. ARIA-E is a transient phenomenon that generally resolves over the course of a few months. There are other processes that may mimic ARIA-E. The first of these are artifact or other processes that may impair CSF suppression. On the bottom is an example of someone receiving supplemental oxygen causing hyperintense signal on the flare sequence within the sulci, which may mimic ARIA. Other processes that may mimic ARIA include posterior reversible encephalopathy syndrome, evolving subacute ischemia, and inflammatory CAA. So these processes may have similar imaging findings of ARIA, such as this example on the top of a patient with CAA-related inflammation and T2 hyperintense signal within the temporal lobes involving the cortex and subcortical white matter. A main differentiator here, though, is the clinical history, as ARIA occurs in patients receiving amyloid-targeting therapies. Next, we'll move on to the imaging findings of ARIA-H. So ARIA-H may take the form of cerebral microhemorrhages or superficial siderosis. So microhemorrhages have the similar appearance to those that we may see in cerebral amyloid angiopathy, so hypointense rounded foci in the parenchyma in a peripheral distribution that must be differentiated from a coursing vessel. Superficial siderosis, again similar to maybe seen in other processes, appears as a curvilinear hypodensity along the cortical sulci, also to be distinguished from a coursing vessel. It must be noted that for detection of ARIA-H, we must use appropriate sequences. These are T2 star weighted sequences, and a GRE was what has been used in recent clinical trials. Susceptibility weighted imaging may also be used, and in the later portion discussing the imaging protocols, we'll review some of the details and benefits of each of these sequences versus the other. Note that ARIA-H again requires specific, appropriately performed sequences to be identified, is generally not available on standard T1 or T2 weighted sequences, and also are not visible on CT. Specific imaging recommendations for ARIA-H are provided here. First, a consistent imaging approach should be used across serial exams, which we'll again review in more detail later in this section. In the use of T2 star weighted sequences, the echo time is one parameter that must be set appropriately. So for a GRA sequence, the echo time should be 15 to 20 milliseconds at 3 Tesla and 25 to 35 milliseconds at 1.5 Tesla. There are also ARIA-H mimics and pitfalls. These include the presence of susceptibility artifacts at brain-air interfaces, such as often occurs along the sinuses as well as mastoids, and these may either obscure the identification of microhemorrhages or mimic microhemorrhages. There may also be other artifacts, such as flow artifacts from the torcula that occur in the phase encoding direction and may simulate superficial siderosis. Next, we'll review a few cases. The first is a 73-year-old patient who presents with new T2 hyperintense signal involving the left parietal occipital lobes. There's a few new microhemorrhages in the same region, as well as corresponding region of diffusion restriction. What is this? ARIA, infarct, infection, or PRESS? So here, this is an infarct, and this is differentiated from ARIA by the presence of diffusion restriction. The imaging or the patient's history, again, whether or not they're taking an amyloid targeting therapy is not provided. But again, here the DWI can be used to differentiate, in this case, the diffusion restriction of acute ischemia versus ARIA, which would not have diffusion restriction. The next case is the 75-year-old patient who presents with multifocal flare signal abnormality, corresponding regions of hemosiderin deposition and superficial siderosis, as well as regions of diffusion restriction. In some of the regions adjacent to the hemorrhage, it may be difficult to know whether this is real diffusion restriction versus artifact, but we can confirm there were regions of true diffusion restriction. So again, what is this? ARIA, infarct, infection, or press? And again here, given the constellation of imaging findings, including diffusion restriction, this is an infarct in the late subacute phase. The next case is an 83-year-old patient presenting with new left parietal sulcal effusion identified on the flare, multiple regions of bilateral superficial siderosis, and corresponding diffusion restriction in the sulci. And what is this? ARIA, infarct, infection, or press? Again, the diffusion-weighted imaging is our friend, and the corresponding diffusion restriction in the sulci, along with that flare signal abnormality, leads us to conclude this is infection rather than other etiologies such as ARIA. The fourth case we have is a 66-year-old patient presenting with new bilateral T2 flare hyperintense signal within the sulci as well as the cortex and subcortical white matter. There's no associated microhemorrhages or siderosis on the GRE, and there's no diffusion restriction. What is this? ARIA, infarct, infection, or press? So in this case, there's no diffusion restriction. These imaging findings would fit for either ARIA or press. Next, we go to the patient's clinical history. They're presenting with confusion, headache, and specifically hypertension. And we confirm they are not on amyloid targeting therapies. So in that clinical context, these are findings of press and not ARIA. Next, Dr. Franceschi will review classifications of ARIA-E and ARIA-H.
Thank you so much, Dr. Cogswell. So now we're going to move on to the imaging-based classification of ARIA-E and ARIA-H. So when we think about the classification criteria for ARIA assessment, we often refer to this ARIA radiographic severity grading scale that is the same across all of the different therapeutics currently on the market. And we divide both ARIA-E and ARIA-H as mild, moderate, or severe. For ARIA-E, we assess both for sulcal and or cortical subcortical flare hyperintensity. Meanwhile, for ARIA-H, we subdivided into ARIA-H microhemorrhages or ARIA-H superficial siderosis, and we assess for both of these findings using a heme-sensitive sequence such as T2 star GRE. So let's first take a look at the ARIA-E severity grading. We think of ARIA-E as mild when there is a single site of flare hyperintensity measuring less than 5 centimeters. Moderate ARIA-E is flare hyperintensity measuring between 5 and 10 centimeter or more than one site of involvement, with each site measuring less than 10 centimeters in maximum diameter. And finally, ARIA-E is classified as severe, as in the example on the right side, when the flare hyperintensity measures greater than 10 centimeters in one or more separate sites. Now, in terms of ARIA-H microhemorrhages, it is considered mild when the patient demonstrates 1 to 4 new microhemorrhages. It is considered moderate when we have 5 to 9 new microhemorrhages, as in the example in the middle. And we classified as severe when there is 10 or more new microhemorrhages. And then finally, we have ARIA-H superficial siderosis, which is classified as mild, as in the example on the left, when there is a single site of superficial siderosis. It's classified as moderate when there are 2 focal sites of superficial siderosis, and it's considered severe when there are three or more focal areas of superficial siderosis. So this brings us to our next case. This was an asymptomatic 60-year-old patient receiving anti-amyloid therapies. As Dr. Cogswell already mentioned, clinical history is key. And in this case, we have the baseline T2 flare alongside the ADC, and then the follow-up scan at 48 weeks. And what we see in this instance is that on the follow up scan, the patient developed two new areas of flare signal abnormality in the left occipital and also in the right frontal lobe. The ADC maps help us confirm that there is no restricted diffusion to suggest superimposed cytotoxic edema or infarct. And I can confirm that both of these sites measured under 10 centimeters in maximum diameter. So our question is, what is this? And the options are mild ARIA-E, moderate ARIA-E, mild ARIA-E and moderate ARIA-H, or severe ARIA-E and mild ARIA-H. And in this instance, for this case, the answer is moderate ARIA-E. In this case, again, moderate ARIA-E, since we have two sites with each site measuring less than 10 centimeters and no evidence of cytotoxic edema on the ADC. And interestingly, this patient was asymptomatic. So this instance of ARIA was recognized purely on the basis of the safety monitoring MRI, but went on to develop ARIA-E every time anti amyloid therapy was resumed. Our next case is another asymptomatic patient, 60 years old, on anti amyloid therapies. And in this case, we have the T2 star GRE at baseline and then the T2 star GRE at 12 weeks. And in this case, we have the same question, what is this? And our options are mild ARIA-H, moderate ARIA-H, mild ARIA-E, and mild ARIA-H, or moderate ARIA-E and severe ARIA-H. So in this case, the patient had a single new site of superficial siderosis. So that was mild ARIA-H, superficial siderosis, and then also less than 5 new microhemorrhages. So that was considered mild ARIA-H microhemorrhages. And in this instance, following discussion with the neurology team, we labeled the patient as having moderate ARIA-H. And finally, our last case is a patient on anti amyloid therapies who was admitted to the hospital for decreased consciousness as well as difficulty eating and swallowing. You have serial T2 flare axial views. And our question is again the same. Options are moderate ARIA-E, mild ARIA-E, and moderate ARIA-H, moderate ARIA-E and moderate ARIA-H, or severe ARIA-E. And in this case, the response is severe ARIA-E, since some of these sites were measuring more than 10 centimeters in maximum diameter. Interestingly, in this case, treatment was discontinued and recovery was complete. So, our next case is a patient also on anti amyloid monoclonal therapy. And this patient presented to the ER at 3 months with complex partial status epilepticus. And in this case, we have the baseline T2 flare, the symptomatic MRI at 3 months, and then a subsequent follow up T2 flare at 8 months. And our question is again the same, what is this? And our options are mild ARIA-E, moderate ARIA-E, mild ARIA-E and moderate ARIA-H, or severe ARIA-E and mild ARIA-H. And in this case, the correct answer is mild ARIA-E. As you can see at the 3 month scan, we have interval development of a single site of T2 flare signal abnormality in the left occipital lobe that measures less than 5 centimeter in maximum dimension. And this has nearly completely resolved on the subsequent follow up scan at 8 months. And then another case, this is a 67-year-old patient receiving anti amyloid therapies, also asymptomatic. So we have the GRE scan at 16 weeks and then the follow up safety screening scan at 25 weeks. The question is, what is this? Options are mild ARIA-H, moderate ARIA-H, mild ARIA-E and mild ARIA-H, or moderate ARIA-E and severe ARIA-H. So this was consistent with moderate ARIA-H. The patient had developed two sites of superficial siderosis in the left frontal lobe and in the right occipital lobe, and had also went on to develop new microhemorrhages that measured under 10 total. And this patient remained asymptomatic. So with that, I will hand it over to Dr. Cogswell, who will discuss in more detail MRI protocols as they pertain to ARIA monitoring.
All right, first we'll discuss MRI protocols for ARIA detection. The field strength used for ARIA detection would ideally be 3T and a minimum of 1.53. The key sequences are FLAIR for ARIA-E detection, GRE for ARIA-H detection, and DWI to differentiate ARIA-E from acute ischemia. The FLAIR may be acquired using either a 2D or 3D technique, whichever is performed consistently in your practice with high quality. The importance is to choose one approach and use that consistently over all time in patients. For the GRE, again, an appropriate echo time is important for sensitivity of that sequence. And I'll note again that the GRE is the sequence that has been used in recent clinical trials and on which the ARIA severity score system is based. Susceptibility weighted imaging is also available in many practices and is more sensitive for the detection of heme products. Many practices are choosing to implement an SWI, and when doing so, it should be noted that a more conservative treatment approach may be taken. For example, if a few more microhemorrhages are detected on the SWI than would have been detected on a GRE, a patient may either be excluded from therapy based on appropriate use recommendations or therapy paused based upon moderate ARIA-H when perhaps it may not have been for GRE counts. So the choice of the hemosiderin sensitive sequence is very important in establishing your imaging protocols. And a reminder here that gadolinium contrast is not needed for a standard ARIA evaluation. In doing our ARIA evaluation, for optimal detection, it is important that a consistent standardized approach is used for imaging across all serial time points in a patient. Ideally, a patient would be imaged at the same field strength, scanner vendor, and model, and using the same sequences and sequence parameters across all serial exams. A particular note for the detection of ARIA-H, same field strength is important, as our sensitivity for detection of heme products scales with the field strength. For ARIA-E detection, differences in vendor may result in differential appearance of the occipital white matter, as well as in sometimes the cortical sulcite, leading to potential ARIA-E mimics. To aid in practices using a consistent standardized approach, the ASNR has collaborated with the major MR vendors to provide protocols for download and use in imaging this patient population. To address some of the questions that have come up regarding the feasibility of implementing dedicated protocols, I'll note that a standard MR brain without could be used for this application. Again, noting appropriate imaging parameters for the sequences, and most importantly, that the echo time for that gradient echo sequence is set appropriately. Next, we'll move on to clinical imaging workflows. And shown here an example of clinical imaging workflows for 3 patient scenarios related to AD therapy. The first of these is the baseline evaluation, which may be termed the AD therapy enrollment exam. The second scenario is the AD therapy monitoring exam, so standard monitoring of the asymptomatic patient on therapy. And the third scenario is a patient on amyloid-targeting therapy who presents with new symptoms. And what is shown here is a proposed workflow in which a parallel naming convention is used for the MR brain order, the imaging protocol, and reporting template, with the goal to ensure that the appropriate imaging is performed and that the radiologist knows the relevant findings that should be reported on the exam. For example, the AD therapy enrollment exam is in many instances and in many practices one and the same as the dementia exam. So it would include the 5 standard sequences of such an exam, and the key findings would be related to those which are used to determine a patient's eligibility for therapy, which we'll review shortly. For the AD therapy monitoring exam, again, standard naming conventions for the protocol and reporting template. And in some practices, an abbreviated protocol may be used for this purpose to help accommodate high scan volumes. Now, finally, I'll note the symptomatic patient on therapy may follow the same workflows as an AD therapy monitoring exam, potentially with the addition of additional sequences depending on the patient's presentation. So next we'll review the relevant findings to be reported in that baseline or AD therapy enrollment exam. And these are, again, findings that are used based upon appropriate use recommendations to determine a patient's eligibility for therapy, which is based upon the association of these findings with an increased risk for ARIA. So the report should include the number of microhemorrhages, new regions of superficial siderosis, white matter hyperintensity burden, if can be reported using the Physicus scale, with Physicus of 3 or severe white matter hyperintensities considered exclusionary, the extent of cortical and subcortical infarcts, as well as other lesions that may be considered exclusionary from treatment, such as an aneurysm or vascular malformation. Reporting templates that include these relevant findings are available for download from the ASNR website, as shown here, as well as through the QR code. And these templates may help have a standardized approach as well as clear communication with the reporting providers regarding the both baseline assessment as well as ARIA reporting. And shown here and is an example of such a PowerScribe template for that baseline or AD therapy enrollment MRI. Again, serves as a reminder the radiologist of the key findings to be reported. I think one of the most important aspects of this is that we need to be specific and we need to include a number of microhemorrhages and avoid statements such as few scattered cerebral microhemorrhages, which may require a repeat read of the exam when the provider wants to know exactly how many microhemorrhages there are to aid in that risk-benefit discussion with the patient looking to be enrolled on therapy. And here is an example of such a report for that baseline MRI. This patient has a single microhemorrhage, so total microhemorrhages, one present in the left occipital lobe, and ideally include an arrow on the exam or a series number and image. Then no superficial siderosis. Grade the white matter hyperintensities as mild and note the absence of infarcts or other relevant lesions. Next, Dr. Franceschi will discuss the ARIA monitoring exam.
So let's first review the MRI schedule for ARIA monitoring for patients that are receiving lecanemab. Each patient will typically receive about 5 MRIs in the first 12 months of therapy. We have a baseline safety screening MRI that's typically obtained within 6 months of enrollment, and then subsequent safety screening MRIs at 2 months, 3 months, and 7 months of treatment. A certain percentage of patients will also receive an additional MRI scan at approximately 12 months, and this is typically performed in patients who are either ApoE4 carriers and or had prior instances of ARIA. Now, every time a patient presents with clinical symptoms that are suggestive of underlying ARIA, an additional unscheduled safety monitoring MRI should be immediately performed. Now, when we take a look at the MRI schedule for ARIA monitoring in donanemab patients is quite similar. These patients will receive 6 MRIs in the first 12 months of therapy. We again have a baseline scan within 6 months of enrollment, and then subsequent scans at approximately 2 months, 3 months, 4 months, and 7 months, as well as an additional safety screening MRI at 12 months for patients who are either ApoE4 carriers or had prior episodes of ARIA. Similarly to lecanemab, any patient presenting with neurologic symptoms that are suggestive of the development of ARIA should immediately receive an unscheduled safety monitoring MRI. And just one thing to highlight, as you can see, the monitoring schedule is quite aggressive in the first 12 months of therapy. And the reason for that is that studies have clearly indicated that ARIA is most frequent early on in the treatment course and specifically in the first 12 months of therapy. So let's discuss the MRI protocols for ARIA detection when we think about follow up scans. Ideally, we should use the same scanner if possible, and if not, then the same field strength. 2D versus 3D flare should be consistent with whatever is most feasible at your institution. And similar to the baseline scan, consider using both so that there is no confusion if patients get one or the other in subsequent studies. Similarly, you should avoid switching between GRE and SWI sequences, with a caveat that microhemorrhages should be reported on the basis of GRE findings, and typically, the heme sensitive sequence used for ARIA-H detection should be documented in the technique of the report. Any new abnormalities should be clearly documented and communicated with the treatment team, and we'll discuss about the pathways of closed loop communication later on in this talk. And finally, the ARIA severity classification scheme needs to be used in the report. So both ARIA-E and ARIA-H need to be classified as mild, moderate, or severe. So here I also have an example of the MRI reporting template for follow-up MRI scans. And these templates are also available on the ASNR website. They are quite standardized and really focus on implementing the verbiage from the ARIA classification scheme into the impression of a report. This is really crucial for neurologist decision making, and especially early on at my institution, we got a lot of requests for report addendums when the report findings and impression didn't comply with the expected standardized reporting template. So here, this brings us to a example of a follow-up MRI report. In this case, we have the baseline T2 flare and GRE sequence, and then also the follow-up safety monitoring MRI. And in this case, the patient went on to develop findings of moderate ARIA-E. As you can see, there was new interval flare signal abnormality in the bilateral occipital lobes and on both sides measuring under 5 centimeters in maximum diameter. The patient also developed findings of severe ARIA-H microhemorrhages, and the patient went on to develop 13 new microhemorrhages in the left occipital lobe. And finally, the patient did not have any areas of superficial siderosis, so no evidence of ARIA-H superficial siderosis. Here we have another example. This was the same patient coming for their 3-month follow up MRI. We again have the flare sequence and also the GRE. So in this instance, as you can see, the abnormal flare signal abnormality in the occipital lobes completely resolved. So there was no evidence of ARIA-E and interval complete resolution of ARIA-E since the immediate prior MRI. The patient had, again, the 13 microhemorrhages in the left occipital lobe. So this was still consistent with severe ARIA-H, but unchanged from prior MRI. And this is what you typically look for in these patients on follow up scans with ARIA present. You assess for the resolution of ARIA-E and you assess for the stabilization of ARIA-H. And again, since the prior MRI scans, there was no interval development of superficial siderosis, so findings were also negative for ARIA-H superficial siderosis. Now, I'd just also like to take a moment to introduce you to various AI solutions that are currently in active development to aid in efficient and accurate ARIA diagnosis. And there's actually currently a single FDA approved tool on the market that's available for clinical use. All of these AI tools in development typically provide the location and count of new microhemorrhages and or superficial siderosis in order to effectively assess for ARIA-H. They also measure volumes of edema and or local effusions in terms of assessment for ARIA-E. They display longitudinal plot graphs across serial prior MRIs to help us reflect and assess dynamic changes over time and display criteria for grading ARIA severity. A recent study published in JAMA Neurology clearly showed that radiologists' detection performance improved when using AI tools for the assessment of both ARIA-E and ARIA-H. And this, as you can probably already guess, was particularly helpful in detection of mild ARIA-E. So, for example, for mild ARIA-E, the sensitivity for detection was 70% in assisted reads and 47% in unassisted reads. So here I have an example of an ARIA-E and ARIA-H report from Icometrics, so IcoBrain ARIA, and this specific tool is currently FDA approved and available for clinical use. I also have an example of a tool that's currently in development and about to enter clinical practice. So these are the ARIA-E and ARIA-H report from NeuroQuant. And I think really the thing to realize here is that these products are quite similar, and they will again focus on detecting flare signal abnormalities for the detection of ARIA-E, and then either microhemorrhages or superficial siderosis on heme sensitive sequences for the detection of ARIA-H. They will also provide the classification according to the ARIA severity scheme and assess for differences over time. So, with that, I will turn it over back to Dr. Coxwell, who will discuss ARIA management in further depth.
All right, thank you. So ARIA, we described the radiographic findings of it and have mentioned that ARIA is most commonly asymptomatic and found by the scheduled surveillance MRIs. However, in some cases, ARIA may be associated with mild, vague, nonspecific symptoms such as headache or confusion, and in rare cases may have severe symptoms and require ICU admission, monitoring, and possibly steroid administration, which has been shown to help improve those symptoms. The presence of any clinical symptoms is used along with the radiographic ARIA severity score to determine a patient's eligibility for continued drug dosing. So any new symptoms related to ARIA and any moderate or severe ARIA-E and ARIA-H should lead to the suspension of treatment. After that, monthly brain MRI should be performed until the resolution of ARIA-E and stabilization of ARIA-H. At that point, informed decision making between the patient and provider will help inform the decision whether or not to continue therapy. And many cases, the patient will resume therapy. It is, however, recommended for appropriate use criteria that a patient with any severe symptoms or severe ARIA, that patient should have the therapy should be permanently discontinued. With a special note regarding patients on amyloid targeting therapy presenting to the emergency department with stroke-like symptoms, as this scenario has been associated with a few deaths. And that requires really heightened awareness of potential poor outcomes in these patients. So, when a patient presents with stroke like symptoms, it is important to first know if they are on an amyloid targeting therapy. And there have been multiple approaches to increase this awareness, such as medical ID bracelets or alerts within the medical record system. When that patient presents to the ER for imaging, often a CT is performed. And ARIA-E on CT may look very similar to acute ischemia. It's therefore very important that an MRI is performed. Again, using diffusion-weighted imaging to help differentiate ARIA-E from acute ischemia, as well as to evaluate for ARIA prior to determining potential intervention in a patient with acute ischemia. Finally, we'll discuss communication of ARIA findings with the multidisciplinary team. So it's been found very helpful in multiple practices to have a multidisciplinary team that meets regularly to both discuss a patient's eligibility for treatment as well as potential complications or question regarding existing patient care. The baseline evaluation of patients in some practices has been done very much like a tumor board, where multiple disciplines meet together, present data, and then a group decision is made regarding whether or not to recommend treatment for that patient. Once a patient is on treatment, again, clear, timely communication is needed between the radiologist and the provider. This is aided by the use of the standard reporting templates that we have discussed. And specifically, as is done in our standard clinical practice, when there are urgent or actionable findings, such as moderate or severe radiographic ARIA, closed-loop communication with the provider is recommended. In summary, radiologists play a key role in detecting ARIA in patients receiving AD therapies. It is important for radiologists to recognize ARIA in multiple clinical settings. These include the scheduled outpatient brain MRIs, as well as potentially the symptomatic patient presenting to the emergency department. Radiologists should be familiar with the key sequences that should be included in the MRI protocols and the radiographic findings of ARIA-E and ARIA-H, as well as the severity scoring system. We encourage that practices establish standardized imaging protocols, as well as imaging workflows, including the ordering processes and reporting templates for ARIA. It has been found helpful to have multidisciplinary meetings with multiple stakeholders in the process to aid in appropriate decision making in a patient's treatment eligibility, as well as evaluating patients through the course of therapy. And we'll end with, again, a note of caution in patients presenting to the ER with stroke-like symptoms who are receiving anti-amyloid immunotherapy. It is, again, very important to obtain a brain MRI to assess for ARIA before considering any potential intervention. Thank you for your time, and we hope you have enjoyed our program.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Lilly.